There is an issue about domestic violence in itself, that it is still stigmatized and misunderstood in our society, and the research has shown that health professionals struggle with whether it is part of their role to address, whereas in fact we know domestic violence is a public health problem. There are a number of different factors that have been identified for clinicians, including issues like lack of time, lack of knowledge about it, uncertainty about what to do. But the biggest barrier, I think, is about the nature of domestic violence and the stigma that it holds. We used a variety of different strategies, partly because we called it herding cats, and knowing that we were going to have to use different approaches for different clinicians within each of the practices. We had Jean Fader as a peer GP who could model good practice around domestic violence. We made our training adult friendly so that it was appropriately geared to bright professional people. We provided materials that were simple and clear, and probably our most important was that we developed partnership with the third sector and appointed advocate educators who could follow our initial training on, because it's pretty clear, no matter what the research or the project, if we do flash in the pan training, it will have an initial impact and then disappear. I think we have done remarkably well, not just in the difference between the control and intervention practices in their behaviour around good practice, but also in clinicians reporting that they have a different attitude to domestic violence, they're much more confident about what to do. Another way of looking at our success is to do with the women themselves. Of course, it's the patients that matter, and women who have been reportedly suicidal, despairing, isolated, are now saying, because of that change in clinician behaviour, they've received the help that they need. Both our advocate educators were remarkable women and absolutely critical to the success of the project in a number of different ways. Clinicians are more confident to refer patients to people that they know, to a named face, to somebody that they recognise. We realised as the project went along that clinicians didn't really understand what domestic violence services did. And by making the links, seeing people within the practice and explaining and giving them feedback on the work that they were doing with women, clinicians got to refer to somebody that they knew, somebody that they understood, and somebody that they trusted to do a good job for the patients.